At the San Antonio Breast Cancer Symposium 2024, we presented an international core study that looked into the association between risk-reducing surgeries and survival in the specific cohort of BRCA carriers with breast cancer. So we have looked into a large network, the so-called BRCA BCY Collaboration, so a large network of 109 centers worldwide that included a young patient diagnosed with invasive breast cancer, early stage breast cancer between January 2000 and December 2020. All the patients were young at diagnosis, so 40 years or less, and all of them were known to carry germline pathogenic or likely pathogenic variants in the BRCA genes. And within this course of 5,290 patients, so all young BRCA carriers with prior history of breast cancer, we have looked into the potential beneficial effect of risk-reducing mastectomy as well as risk-reducing salpingo-oophorectomy in terms of reducing mortality as well as disease-free survival and breast cancer-free interval. The study is a retrospective international multicenter hospital-based core study, the so-called BRCA BCY Collaboration. And within this large network, we managed to include more than 5,200 young BRCA carriers with breast cancer. And in this special analysis, we looked into risk-reducing surgeries. However, the network was started many years ago to try to answer the question. And the first question that was answered with this study was the safety of having a pregnancy after being diagnosed with breast cancer in this special cohort of patients. These results were published in JCO in 2020 and then in JAMA in 2024. At San Antonio 2024, we presented within the same consortium the data on risk-reducing surgery in this special cohort of patients. In the study, we have seen that around half of the patients included received one or the other risk-reducing surgery, and 1,804 patients received both risk-reducing surgery and risk-reducing mastectomy and risk-reducing salpingo-oophorectomy. Looking first at risk-reducing mastectomy, this surgical procedure was associated with a significant improvement in overall survival, with an adjusted hazard ratio of 0.65, so a 35% reduced risk of dying for those patients that underwent risk-reducing mastectomy. And these results was consistent with all the different models, sensitivity analysis that we have done to try to counteract on the potential biases with this sort of analysis. This benefit was observed across all the subgroups that were analyzed, and risk-reducing mastectomy was also associated, as expected, with a significant improvement in disease-free survival and breast cancer-free interval, with adjusted hazard ratio of 0.58, 0.55 respectively. And this is mostly due to the major reduction in the risk of developing a second primary breast cancer for those patients that underwent this surgical procedure. On the second part of the analysis on risk-reducing salpingo-oophorectomy, in this case, also this surgical procedure was associated with a significant improvement in overall survival, adjusted hazard ratio of 0.58. And again, the result was consistent in all the different models that we have used. The main difference with the prior analysis is that the median time from diagnosis of breast cancer to risk-reducing mastectomy was less than 1 year, was 0.8 years. In this case, was around 3 years after diagnosis of breast cancer, and the median age of the patient at the time of this procedure was around 40 years, so in line with the guidelines on risk-reducing salpingo-oophorectomy. Interestingly, the subgroup analysis, we have seen that the benefit of risk-reducing salpingo-oophorectomy was greater for patients for BRCA1 carriers and for those with triple negative disease more than in BRCA2 carriers or those patients with ER-positive, HER2 negative disease. Main explanation is that ovarian cancer risk is higher for BRCA1 carriers than BRCA2 carriers, and BRCA2 carriers have a risk of ovarian cancer at an older age as compared to BRCA1 carriers. So the patient we included were very young, so and the follow-up was 80 years, but still not probably enough to see ovarian cancer event in the BRCA2 cohort. So that's why probably the benefit is mostly observed in the BRCA1 cohort. And for the tumor subtype, this is probably related to the different distribution of subtypes in the BRCA1 and BRCA2 population, with BRCA1 mostly affected by triple negative disease and BRCA2 mostly by ER-positive, HER2 negative disease. And the final point on the benefit of risk-reducing salpingo-oophorectomy in improving the disease-free survival and breast cancer-free interval with adjusted hazard ratio of 0.68, 0.65 respectively. And this is driven by both a reduction in the risk of developing a second primary breast cancer and a second primary ovarian cancer. In the final analysis, we looked into the independent effect of the two surgical procedures, so to see the benefit was observed also for those patients that underwent one and not the other surgical procedure. For overall survival, there was no interaction, so the benefit of these two surgical procedures was independent. For disease-free survival, breast cancer-free interval, we observed that the effect of risk-reducing salpingo-oophorectomy on these outcomes was more pronounced in patients who also underwent risk-reducing mastectomy, because the second primary breast cancer counts as an event for disease-free survival breast cancer-free interval. And so those patients that underwent also risk-reducing mastectomy had a further reduced risk of developing a second primary breast cancer. These results should be applied in the special patient population that we have included in the study, meaning young women with diagnosis of breast cancer at the age of 40 or less, and all known to carry a BRCA pathogenic or likely pathogenic variants, meaning that these results do not apply to BRCA healthy carriers or BRCA carriers with the first breast cancer diagnosed at an age older than 40. So in this special population, what we have seen is a clear and strong value in terms of improving the outcomes of this patient for both surgical procedures, so both risk-reducing mastectomy as well as risk-reducing salpingo-oophorectomy. So I believe that the counseling of this special patient population on this surgical procedure should be more reinforced as compared to what we were used to do, particularly for the risk-reducing mastectomy, which is probably the most important news out of this study. For the risk-reducing salpingo-oophorectomy, I will stick to the guidelines. So recommended age is 35 to 40 years for BRCA1 carriers, 40 to 45 for BRCA2 carriers, with important fertility counseling because of all the reproductive implication of this surgical procedure. For the risk-reducing mastectomy, based on this data, will be a bit more pushy into the counseling of undergoing this surgical procedure for these very young women at the time of diagnosis of their first breast cancer.